Welcome you all to my today's presentation. I am Professor Colonel retired Shormin Ferdousi from Bangladesh, which is located in South Asia, and our population about 171 million. My today's discussion topics is high dose methotrexate and leucovorin rescue therapy in childhood malignancies experience in resource limited country. Study period was July 2014 to December 2015, and place of study was Combined Military Hospital, Dhaka, Bangladesh, because at that time I was in service, and I have done it in Department of Pediatrics Department of CMH, Dhaka. Acute lymphoblastic leukemia, that means ALL, is the most common childhood malignancy and a leading cause of childhood cancer death. Non-Hodgkin's lymphoma, NHL, accounts for approximately 7% of cancer. Osteosarcoma comprises 5% of all pediatric malignancies. There is great concern about the quality of life among the directed therapy, which is an integral part of the treatment of pediatric malignancy. The 5 years event-free survival rate is more than 80% for pediatric ALL, and due to advances in neoadjuvant and adjuvant chemotherapy have improved 5 years disease-free survival rate also for osteosarcoma about more than 60%, and for non-Hodgkin's 80 to 90%. In late 1960s, Ferdousi et al. Showed that increasing the doses of methotrexate would secure new remissions in patients who had relapsed while receiving the drug at lower doses. High-dose methotrexate is a common component of many chemotherapeutic protocols for childhood malignancy, and some of them have side effects. Prominent side effects are bone marrow depression, mucositis, diarrhea, liver and kidney dysfunction, dermatitis and neurological disturbance. To minimize the toxicity of these drugs, urine alkalinization, vigorous hydration and rescue with leucovorin is needed. Facility for serum MTX level was not available at the time of my study period in Bangladesh, so aim was my study to evaluate the high-dose methotrexate toxicities by monitoring biochemical and serological markers. Inclusion criteria of ALL and NHL patients. These are the inclusion criteria: poor response to prednisolone on day 8, high-risk cytogenetics, CNS involvement, high-risk T-cell phenotyping, partial remission of bone marrow after induction, T-cell NHL and Burkitt's lymphoma stage 4. A prospective observational study was done in 12 children with a confirmed diagnosis of ALL, NHL, Burkitt's lymphoma, non-Hodgkin's and osteosarcoma. Diagnosis of ALL was made by morphology, immunophenotyping and risk stratification was done by cytogenetics. Non-Hodgkin's and osteosarcoma were confirmed by histopathology and immunohistochemistry. Each patient received 4 cycles of high-dose MTX, total 48 cycles for 12 patients. In each course, they received high-dose MTX according to the protocol. All the cycles met the prerequisite criteria of prehydration, urine alkalinization, duration of methotrexate infusion and appropriate leucovorin rescue. And what was the result? This is the sex distribution of study group patients, and this is the percentage of various diseases. And now I want to show the toxicities of high-dose methotrexate in 48 cycles. Among the 48 cycles, we found that neutropenia was the most common toxicity, about 83%. After that, vomiting was 70%, Mucositis was 56%, and we found that raised serum transaminase level only 12%, and only 2 patients had transient impaired GFR. Frequency of what type of toxicity was frequent at that time? Vomiting and diarrhea were most frequent in cycle 2. Mucositis and fever were most frequent in cycle 1. Raised serum transaminase in cycle 3, and 2 patients had less than 100 creatinine clearance. And due to percentage of neutropenia was very high, so we compared other toxicities in relation to neutropenia. So we found that along neutropenia, vomiting was about 75 patients also have vomiting. Mucositis have 57% patients. Fever had 37%, and raised transaminase level 12.5% of patients, and thrombocytopenia only 22% patients. So we can say that the administration of high-dose MTX therapy was found to be safe without any life-threatening adverse effect in a developing country like Bangladesh. Trained nurses, medical staffs, including meticulous monitoring of treating oncologists, is the mainstay of early detection and prompt management of complication if arise. And this is the current status. Our total patient number were 12. Among them, 9 are happily surviving, and their event-free survival rate above more than 5 years. So 9 are happily surviving, I again can say confidently, and among them 3 expired, 1 osteosarcoma due to disease process, 1 T-cell ALL due to very early relapse, and 1 B-cell ALL due to early relapse. Thank you very much. Thank you all for patience hearing.